friends, today I am going to reveal some true facts of new research on endoscopic vs medical therapy for bleeding peptic ulcers with adherent clot. But first of all, I request you to please share and subscribe my channel for getting my informative true facts videos uninterrupted. Please note that subscription of my channel is free of cost. Now, new research on endoscopic vs medical therapy for bleeding peptic ulcers with adherent clot. Upper gastrointestinal bleeding is the most common and potentially life-threatening emergency. Despite great advances in the field of medicine, the optimal management of bleeding peptic ulcers with adherent clot on endoscopy is still controversial. The aim of this study the aim of this research is to compare the combined endoscopic and medical therapy with medical therapy alone for bleeding peptic ulcers with adherent clot, that is forest type IIB. During 2 years study period, around 342 patients presented to tertiary care hospital with acute upper gastrointestinal bleeding. Out of these, 81 patients were noted to have adherent clot during endoscopy and were included in a study. 40 patients received combined endoscopic and medical treatment, whereas 41 patients received medical treatment only. 40 patients received combined endoscopic and medical treatments, whereas 41 patients received medical treatment only. This is important. The baseline characteristic of patients in two groups were comparable and statistically significant. Primary outcome being recurrence of bleeding within 7 days of treatment was less in combined therapy group compared to medical therapy group, 2.5% vs 17.1%. This was statistically significant. Secondary outcome like recurrence of bleed in 30 days and need for repeat endoscopy were less in combined group compared to medical therapy group. These were statistically significant as well. Other secondary outcome like necessary for surgery and mortality were fewer in combined group, but these were not statistically significant. In conclusion, combination endoscopic therapy consisting of epinephrine injection, removal of the adherent clot and treatment of underlying stigmata is more effective than medical therapy alone. Upper gastrointestinal bleeding UGIB. Upper gastrointestinal bleeding UGIB is common and potentially life-threatening gastrointestinal emergency. The annual incidence of hospitalization for acute UGIB is 1 per 1,000 people with a mortality rate of 7% to 10%. Upper gastrointestinal endoscopy (EGD) is the prime diagnostic and therapeutic tool for UGIB. It precisely delineates the bleeding site and determines the specific cause. EGD is 90% to 95% diagnostic for acute UGIB. Patients after initial resuscitation should undergo early endoscopy within 24 hours. It helps to identify stigmata for recent hemorrhage in the SRH in patients with underlying peptic ulcer disease. Patients with high risk SRH like active bleed or visible vessel needs endoscopic intervention to reduce morbidity and mortality. Ulcers with a clean base or with a flat pigmented spot have a low risk of rebleeding and do not require endoscopic therapy. Ulcers with adherent clot carry 8 to 36% risk of rebleeding. The optimal management of ulcers with adherent clot is controversial. It is still controversial. Endoscopic therapies include injection, ablation, and mechanical therapy. The above three endoscopic therapies are effective as monotherapies, but combined therapies increase the efficacy. It is important. Combined therapies increase the efficacy of treatment. Proton pump inhibitor, PPI. It is important. Proton pump inhibitor therapy, PPI therapy, is recommended for patients with acute UZIV. This therapy reduces the severity of SRH at endoscopy and reduces the need for endoscopic therapy as compared with no treatment or histamine 2 antagonist H2 blocker therapy. PPI therapy modestly reduces the risk for rebleeding, need for surgery and blood transfusion. However, so far has not shown to reduce the mortality. The benefits is greatest in patients who have high risk SRH, such as the visible vessel. Although intravenous injections and intravenous infusion is ideal, oral PPI therapy provides much of the benefit. The rationale for PPI therapy is that most common causes of UZIV, including ulcers, gastritis, duodenitis, and hemorrhagic reflux esophagitis, are medically treated with acid suppressive therapy. PPI therapy is also useful for hemostasis. By neutralization of intraluminal gastric acid, it promotes stabilizing of blood clots. Omeprazole has been the most extensively studied intravenous PPI. Others are pantoprazole and esomeprazole. The suggested dose of intravenous pantoprazole is 80 mg followed by 8 mg per hour infusion. Omeprazole and esomeprazole have also been used as 80 mg and by 8 mg per hour infusions. The infusion is usually continued for 72 hours. If there is no bleeding, the patients may be switched to oral pantoprazole 40 mg per day or omeprazole 20 mg per day. Till date, the management of ulcers containing adherent clot has been controversial. Some investigators do not recommend endoscopic therapy for patients with non-bleeding adherent clots because of the potential induced severe hemorrhage in contrast. In contrast, others advocate removal of the overlying clot and treatment of underlying stigmata for patients with adherent clot in an ulcer base. Two recently published randomized controlled trials have shown that injections of epinephrine followed by removal of adherent clot and treatment of underlying stigmata significantly reduced the rate of recurrent ulcer bleeding when compared with leaving the clot undisturbed. However, later on meta-analysis found no clear evidence for need of specific endoscopic interventions in patients with an adherent clot. The purpose of study and the purpose of the research is to compare the effectiveness of combined therapy with medical therapy alone for the patients with bleeding peptic ulcers with an adherent clot. This prospective randomized single center study was conducted in the Division of Gastroenterology, Seri Kashmir Institute of Medical Science, Srinagar, India, over a period of 2 years from November 2011 to November 2013. The study was approved by Postgraduate Clinical Research and Ethics Committee of Institute. Patients who presented with UZIV after initial resuscitation underwent upper GI endoscopy. Patients with adherent clot, which was defined as a lesion that was red, maroon or black and amorphous in texture and that could not be dislodged by suction or forceful water irrigation or on endoscopy, were randomized into two groups. Randomization was done by computer-generated random numbers. One group with adherent clot received medical therapy only, and intravenous pantoprazole 80 mg doses followed by 8 mg per hour infusion for 72 hours. The other group received endoscopic therapy in addition to medical therapy. The endoscopic therapy involved injection of one solution of epinephrine into and around the clot, followed by removal of clot with polypectomy snare. After the removal of the clot, ulcers with underlying stigmata was treated with multipolar electrocoagulation generator setting of 15 W applied for a moderate amount of time, that is 10 seconds, with moderate pressure on the breathing site until formation of white coagulum appears. All patients in the two groups were monitored for 72 hours after endoscopy. All patients in the two groups were monitored for 72 hours after endoscopy. Patients who remained stable at 72 hours were discharged on oral omeprazole 20 mg per daily and followed weekly for 30 days. The primary outcome of the study was to assess the rate of rebleeding within 7 days of treatment in two groups. It is important. The primary outcome of the study was to assess the rate of rebleeding within 7 days of treatment in two groups. Secondary outcome includes 30-day rate of recurrent bleeding, need for repeat endoscopy or surgery, and rate of mortality. Now, exclusion criteria. Age less than 15 years, pregnant and lactating women, patients not giving written informed consent, patients with comorbidities like liver disease, GI malignancy, CKD, systematic infections, cardiovascular and pulmonary disease, patients with previous gastric and reducing surgeries, just vagotomy, gastric resections, patients on anticoagulants. Now, a statistical analysis of all these findings. Data analysis was performed using the SPSS version 20 IBM. Continuous variables were expressed to mean. Independent sample T test was performed for continuous variables, and chi-square test or Fisher's exact test when appropriate. For discrete variables, a value of less than and greater than 0.05 was considered statistically significant. Primary outcome: recurrence of bleeding within 1 week of treatment. Recurrence of bleeding within 7 days of treatment occurred in 9 patients, about 11.1%. Recurrence was lower in the combined therapy group compared to medical therapy group at 2.5% vs 19.5%. This was statistically significant and p-value of 0.029. Now, surgical therapy within 30 days. Surgical therapy for treatment of bleeding ulcers within 30 days was less in combined therapy group compared to medical therapy group, 0% vs 2.4%. But this was statistically insignificant with p-value of greater than 0.999. Mortality with 30 days. Mortality within 30 days was less in combined therapy group compared to medical therapy group, and again statistically insignificant with p-value. The management of non-variceal UCIB has evolved immensely over a period of decade or so, with the availability of PPIs and endoscopic therapy. But the optimal management of bleeding peptic ulcers with adherent clot is still controversial. The purpose of our study was to address the controversy in the management of bleeding peptic ulcers with adherent clot. The present study is the largest randomized prospective study to compare combination endoscopic and medical therapy with medical treatment only, peptic ulcers with adherent clot, and to evaluate the effectiveness of combination endoscopic therapy in a clinical setting. Non-bleeding adherent clots are commonly identified when endoscopy is performed for acute upper GI bleed. The study by Laine et al. Considered of young, low-risk patients and found that the rates of recurrent bleeding for patients with adherent clot treated with the medical therapy were as low 8%. Laine et al. Found the endoscopic therapy was effective. Endoscopic therapy was effective for active bleeding and a non-bleeding visible vessel, but not for a clot. In the randomized controlled study of 27 patients with adherent clots, Jensen noted recurrent bleeding rates of 33% for patients treated with a heat probe, 37.5% with injection therapy, and 30% with medical therapy. Based on these findings, these investigators recommend that adherent clots should not be forcibly removed and be managed with medical therapy. Recent study by Jensen's randomized 32 high-risk patients with severe upper GI bleed due to ulcers and not bleeding adherent clot resistant to target irrigation to combination endoscopic or medical therapy. Combination endoscopic therapy consisted of epinephrine injection showing the clot down with cold and multipolar electrocoagulation of underlying stigmata. The frequency of recurrent hemorrhage during hospitalization was significantly lower in patients treated with combination endoscopic therapy than in those treated with medical therapy alone. Similar findings were reported by Blue, who randomized 56 high-risk patients, 56 high-risk patients with severe GI bleed due to ulcers and non-bleeding adherent clots resistant to target irrigation to receive combination endoscopic treatment and a study group compared with the medical therapy only. During this study, found rates of recurrent bleeding within 7 days of endoscopy in high-risk patients treated with combinations endoscopic therapy were significantly lower than those treated with medical therapy group. Combinations endoscopic therapy was also associated with a significant decrease in the length of hospitalization, less number of packed red blood cell transfusion after endoscopy, the need for repeat endoscopy, and the recurrent bleeding within 30 days compared with medical therapy only. Kim in their study on adherent clot found that endoscopic therapy significantly reduced the bleeding related mortality. All-cause mortality, however, there was no difference between endoscopic therapy and medical therapy regarding rebleeding. Our results were similar with most of the recent studies. The rates of recurrent bleeding in patients treated within 7 days with combination endoscopic therapy were significant, and it was lower than those treated with medical therapy only. In addition, combination endoscopic therapy was associated with a significant decrease in recurrence of bleed within 30 days and the need for repeat endoscopy compared with medical therapy only. The need for surgical interventions for ulcers and the 30-day mortality rates were also lower in the endoscopic therapy group in the study, but these differences were not statistically significant. Conclusion: combination endoscopic and medical therapy is more effective than medical therapy alone. It is important. Combination endoscopic and medical therapy is more effective than medical therapy alone for bleeding peptic ulcers with adherent clot. Any patients presenting with non-variable UGIV should be immediately started on PPIs, preferably IV burst followed by infusion for 72 hours. After initial resuscitation, patients with bleeding peptic ulcers with adherent clot should be taken for early endoscopic intervention followed by medical therapy. In my next video, I will reveal some true facts of other important topics. Thanks.